our friends from all over the world. My name is Dr. Kiano Shah. Today at the 2020 Peer-to-Peer Global Interdisciplinary Summit, we have two special guests, very well-known, seasoned international lecturers and influencers in the profession of dentistry. I would like to introduce today's host, Dr. Arun Garg, before we start the session, and Dr. Arun Garg will give you details about our speaker today. So once, maybe twice in a generation, does a truly transformative leader emerge in any given field. For dentistry, that leader is Dr. Arun K. Garg. For more than 25 years, Dr. Garg has transformed dentistry from both the patient and practitioner perspective, performing innovative surgeries on more than 200 days a year, and also lecturing around the country on a variety of cutting-edge dental procedures. Every time I turn on any of my social media, he's in a different city doing something different. It's mind-boggling how he can still manage to practice and do these surgeries back at the home office. As the co-discoverer of the platelet-rich plasma, PRP, and the preeminent authority on advanced bone grafting, Dr. Garg's teachings and signature instructional style are sought out across the United States and around the world. Dr. Garg is a highly respected clinician and educator in the field of implant dentistry. Well, folks, let's add a little bit more to this story. Dr. Garg is considered the world's preeminent authority on bone biology, bone harvesting, and bone grafting for implant surgery, and has created lectures and hands-on educational courses in those specialties. Dr. Garg is also the founder of Implant Seminars, the nation's largest provider of dental implant continuing education, and is the author and publisher of 7 books. I believe he's recently launched this morning at 2 or 3 a.m. his 8th book, which is free to all by going to that link that we will provide. Practical implant dentistry, a thorough understanding, bone biology, harvesting, grafting for dental implants, rationale and clinical applications, dental and craniofacial applications of platelet-rich plasma, dental implantology dictionary, implant dentistry, the practical approach, practical soft tissue management or natural teeth and dental implants, and on it goes, which have been translated in multiple languages and distributed worldwide. He maintains several practices in Miami Beach and Fort Lauderdale, Florida. Thank you very much for hosting the session, Dr. Arun Garg. I will turn over to you.
Hey, welcome everyone to all the participants that are gathered here for this global summit. You know, when this pandemic hit and we all were quarantined during this time, is under this banner, the Global Summit, and additionally another banner, the IDIA, we organized a series of free webinars. Under this banner, Global Summit, the 100 top speakers around the world that are members of the 100 Top Speakers organization were all contacted and asked if they would volunteer and donate their full webinar that they would normally give as a lecture at the major symposiums around the world. And they've all accepted the invitation. What you're getting in 24 different time zones is all over the world, the top 100 lectures that are given at all the national and international symposiums that normally cost dollars to go and travel and registration fees and hotels, all at no charge, all from the comfort of your own home. This is unprecedented to be able to do this. And what's happened is the dental community has been looking for something. As of last night, over 400,000 dentists have viewed one or more of these webinars since we started this on April 1. We plan to continue this until May 30th, as we anticipate and fully expect that 1 million dentists will tune in to one or more webinars by then. Is all of the presenters are on board with sharing this information freely and completely. Is we're all in this together with this pandemic. We're all going to come out of this together. We're here to support you. With that said, I'd like to introduce today's speaker, Dr. Kayvon Javid. What we had started doing in the early 90s is, as Keenar Shah said, develop platelet-rich plasma, taking blood from a patient, spinning it in a simple centrifuge with a simple test tube, and collecting the middle layer to get the concentrated platelets, concentrated fibrin, and concentrated white blood cells to add it to our bone grafts easily and inexpensively to enhance the soft tissue and the hard tissue. His topic is exactly that, grafting without borders, meaning available to everyone at nominal, little to no cost. His credentials: he's a graduate of the University of Southern California, got his Bachelor of Biology in 1995. He then went on to do postgraduate studies in neurobiology and got his degree there in 1997, and then went on, of course, to dental school, got that degree in 2001. After that, he's a faculty member, past faculty member of the University of Southern California in their AEGD program. He's also been investigator and clinical advisor of the DIO implant. He's also the CEO of the Global Implantology Institute, co-founder of the Global Implantology Summit, founder of the Dr. Smile Dental Group, founder and director of the Phlebotomy Educators Educational Forum, and CEO of South Bay Implant Institute, along with being the co-founder and editor of the International Journal of Growth Factors and Stem Cells in Dentistry. He has his diplomat in the ICOI, fellowship in the California Institute, and the Academy of Osseointegration. He's a faculty and board member of 4M Institute, advisory board member of BioLays Laser Company, board member of Community's Child, a nonprofit Christian organization, and an international speaker, and has published numerous articles and many reputable magazines and journals. I'm going to turn the floor over to Dr. Javid to present on how to enhance bone grafting now in 2020 easily and for each and every general dentist out there. Dr. Javid?
Thank you, Dr. Arun. I'm honored. One effort for you guys to do all this. I'm really honored to be here. Also honored for you to be hosting my webinar. Thank you. So I guess we're going to share my screen, guys, here. Perfect. Thank you. All right, so let's get started here. So this is our world before the corona virus, and now I've kind of updated it. It's an unfortunate event that's happening to us. I know all of my colleagues are pretty much involved with this, but hopefully it is soon over. Yeah. So this lecture basically is about incorporating phlebotomy and PRF into dental practice, and I like to do things in a simple way. That's my way of life, basically. I don't like complications, and doing things that are difficult. Because it's not good. That's not good for me or for my patients. You want to get the patients in. You want to be, comfortable. It has to be easy enough. And my experience in the past 6-7 years is that this is really has added a layer to my practice that I can tell you that it's increased the productivity. And also so much comfort. I get so much referral from my patients, and I believe it's easy enough that most general practitioners can do this. And we'll talk about all the benefits. But just like you, I was, I had doubts about investing, and who would want another layer of complications or items and inventory to basically to purchase. But let me tell you, it's all worth it, because at the end yeah, you'll see that the benefits outweighs the cost, and obviously the learning curve that you have to go through. Also, if once you start with phlebotomy and you get good at PRF and drawing blood and all that, if you would like to continue your basically education in getting maybe an IV sedation, this will help you tremendously, because the hardest thing is is obviously establishing an IV for a patient. So this will help you in that regard. This is a small video that I would like to play. This, I'm not going to play the whole clip. This is from Jay Shetty. This is just about learning, and I believe that I'm a forever student, and this is a very empowering video. Let me see.
Marcus Aurelius hired an assistant to follow him as he walked through the Roman town square. The assistant's only role was to, whenever Marcus Aurelius was praised, whisper in his ear, "You're just a man. You're just a man." They say two things define us: our patience when we have nothing, and our humility when we have everything. The greatest thinkers on the planet believe that they're perpetual learners, perpetual students of reality and of life. And it was actually Maya Angelou who said that actually I've learned that I still have a lot to learn. The person that we will become in 5 years is defined by the people that we spend time with today and the books that we read today. That's why who we associate with, who we spend time with, who we absorb our energy with will really define what's on our mind. And often what limits our learning is that we believe we already know. We believe that we already have knowledge. We already believe that we have the answer. But actually opening up ourselves to learn from the people around us, selectively choosing people who can be guides and wise advisors, we often find that this feeling of knowing makes us actually judge others and criticize others. And that's why we see that judging is critical, but observing can be educational. And therefore, we should be so focused on improving ourselves that we don't have any energy to criticize anyone else. And
well, I won't play the whole clip, but yeah, I really enjoy it. I can watch that video every day, pretty much, and it'll give me a lot of motivation. So why would we want to incorporate blood drawing in our practices? So the first reason would be healing. And obviously, we want to see results. And ultimately, we can't deny that revenue or finances are obviously very important. So let's start with the healing. Healing takes places in 3 stages. The first stage is the inflammatory phase. The second phase is the proliferative phase, and the last stage is the maturation phase. So these blood derivatives are involved in all these 3 phases, and this is well documented in the literature out there. We're not going to spend time on that. So what do we tell our patients? I know there are brochures available, but you can make your own, or it's very important for your staff to know, or how to communicate this with the patient, that why are you going to draw the blood. So basically stops bleeding. I don't know if you ever had patients, if you do an extraction and they go home and then you get a call in the middle of the night saying, "Oh, I'm still bleeding." Well, this is never going to happen when you use this blood derivatives. Faster healing, again, this is well documented by compatibility, and finally, it reduces post-operative pain. Again, there's a lot of literature out there that supports these statements. So next thing is the results. I put this in 100% guaranteed result in just to make a point out of it, because nothing is 100% of the time. So, and there's no guarantee. So I always make sure I tell my patients that that mostly it's a lot of the cases are patient dependent. So patient compliance or patient basically biology has is a big factor in the results. So where can we use this centrifuge blood, autologous blood derivatives? So we can use them in socket grafting, horizontal and vertical ridge augmentation, crestal and lateral sinus lift, immediate implant placement, soft tissue augmentation, the laser-assisted gum lift. That's a procedure that facial aesthetics, and basically here all these cases that I'm going to go over here with you are basically I didn't use any pins or screws or meshes, or in some cases I didn't even use any bone particulate in some of the cases. So the idea is to make things simple, and so you can readily and easily do it for a patient, and in a minimal amount of time. So we're going to go over an example of each of these cases and look at the results. Patient obviously periodontal involved. This is an article from Journal of Current Maxillofacial Surgery. We wrote this paper with my good friend Dr. Carlos Morao, Rafael, and Vittorio. And basically, it is the use of leukocytes and platelet-rich fibrin in the management of soft tissue healing and pain in post extraction sockets. It's a randomized clinical trial. And again, there's a lot of articles out there. I've been biased a little bit here, picking up our own. So looking at the CT scan here, you can see the bone loss, and in most of these images, you can see that the most of the buccal plates or even the lingual plates were gone. So in this case, what I did basically just took out the teeth and put in my sticky bone, and of course we had denture made for the patient ready to go. So in that case, immediately. And it's very important to understand that your immediate restoration is very important in your results. So if you don't have good restorations, if your denture is seating on this grafting area and you don't have a good housing and there's movements or micro movements, your grafting is not going to take. So I'm just going to explain a little bit here about these units that we're going to be talking about a little bit here. So these units are basically, when we're looking at a CT scan image, we're looking at this Heinz-Field dimensional units. Basically, it's a relative quantitative measurement of radio density. So the absorption coefficient of radiation between the tissue, and it produces that gradient of the grayscale. And I compared the different areas of the patient, so we can compare our graft to the patient's own cortical or the cancellous bone. So here we're looking at our graft, which is showing you a maximum of 1262, and the patient's own cortical bone is 1147. Again, when we look at this image, we could see that our graft stayed there pretty much like a tumor, like a glue. It stayed there and it is there, and it didn't go anywhere. And it basically, we not only were able to rebuild that ridge, we were actually able to increase the width of the ridge. Now we have about 9.2 millimeter of width there. We can put any size implants there. So that's an amazing result. So next case that we wanted to talk about is a lateral ridge augmentation. Again, these are the cases that we get day in and day out in our practices, and a lot of times we don't have a good option for the patient. So this is another paper that is combining of autologous particulate dentin LPRF and fibrinogen to create a matrix for predictable ridge preservation. And there's a lot of papers out there. I'm just taking as examples here. So these are the cases, existing bridge for 30 years, and we always have this kind of cases where we have failing abutments. You probably made a bridge, and the patient wanted another bridge, and you made another bridge, and you come to a point where you're losing those abutments. So what's the patient going to do in this kind of cases? So we're going to look at before CT scan here, and you can see how thin this area is. Looking at so we decide to do a Ladderage augmentation. We basically will prepare the site for the grafting. You do have to do decortication, and obviously make things ready for your grafting. If you don't do decortication, you're not going to get this osseointegration or your grafted material to become bone. So here's a sticky bone that we produced. In this case, I decided to overpack. So it's very important to understand that if you overpack, you need to be able to get primary closure. If you don't get primary closure, you can say goodbye to your grafting and the whole effort. So you have to evaluate before putting your graft in that how much graft you're going to put in there. So you basically release tissue. You're going to do score. If you're going to score the tissue or cut through your periosteum, you can do all of that before you place your grafting in. So again, these grafts are very stable. In this case, I'm using also a separate membrane. This is I use two different types of membranes beside the PRF or the PRP gel. So I use either a BioExclude, which is a minimally manipulated allograft immunochronic tissue. It's an amazing membrane, and the results are fantastic. It's super thin, and I've been using that a lot. And the other one that I use pericardial membrane, which is also very thin, and there's also great. BioExclude, of course, is a little bit more pricey, but I would prefer BioExclude over any other membrane. I'm not getting anything from these companies. I just like to share, what works for me. That hopefully that would work for you. And I on top of that BioExclude, I'm also placing a PRP gel or a PRF membrane because I just have it, and it's quite compatible, and I had enough room to be able to basically place that. So we took a CT scan right after the surgery. Obviously, we got a good primary closure, and you can see that out here that this grafting that we placed was not very uniform. So sometimes I actually using my fingers, I try to mold that into that area. Now again, what's very important is to have a housing for this grafting. Okay, you can't have muscle movements or tongue movement or anything like that. Be moving your graft because that will not turn into bone, and it will turn into something, but not bone. But you can see here that it's not very uniform. This is a CT right after, so we're looking at that graft and how much bone we added. So we wait 5 months and we take a new CT scan. And the way I basically housed my grafting here was by making a temporary for the patient that would actually extend out to the buccal into the vestibule a little bit, which will limit movement, and that is key in attaining that result. So now we can see again, our max number here is 982, which is pretty amazing results here. So if you compare patient's cortical, which is 1132, the grafting is 982, and the cancellous bone is 392. So obviously, if we would just place a implant in patient's own bone, the bulk of our implant will be in the in the cancellous bone, which will have a lot less density and that than the graft that we place, which is a 982, almost. So it feels like you're placing your implant in 100% cortical bone. So this is so we waited a long time for this. I wanted to make sure that that we get a good result here. I want a solid bone, so we waited a little bit longer. But you can see that's amazing, right? That's an amazing result. Place our implants. Put our sutures. Take a CT scan. I don't really take CT scan all the time, but this case I knew I wanted to use it for educational purposes. So I usually do a lot of place a lot of implants with the guided surgery system. I also sometimes don't, but this one wasn't a guided system, so I just used freehand. And you can see how well that implant is embedded inside the ridge completely. And so that's a great result. I mean, by not using any pins or screws, which are, by the way, very, very complicated. I have all the pins and screws from different companies, Meisinger and all that. So it's really complicated to use these pins and screws. And there's some complications. But that to me, that's a simple, easy procedure. It only takes few minutes, basically, and you get great results. So here's another case for ladderage augmentation. In this case, when we look at this, the question really is, what would be your treatment plan? I mean, so this patient only has a few teeth on the top, and you would say, let's extract all the teeth and place an, do an all-on-4 or some sort of implant supported restoration. But the patient was actually a very young patient, and she didn't want to lose her teeth. So she just wanted to get some implants done, and she didn't care about the finances. So, but when we look at this ridge, there's nothing there, right? I mean, this is absolutely nothing there to place an implant. So what do you do with your options? And again, in this case, I decided to do a minimally invasive procedure. Again, our treatment plans options would be ridge split, block grafting, GBR, implant supported bridge. So we pull out the other teeth and place the implants. But we decided to just do a freehand sticky bone in the area with some membranes, and waited about 6 months. And in this case, we had enough bone actually to do a guided surgery. So place the implants in a matter of minutes. Again, the key was that fact that we had enough bone. You can see how wide that ridge is. So again, that's great results. And when you can do things in a simple way, I'd rather do that than anything that's complicated, because with that you get patient referrals, and so it adds into your productivity. So next case I want to talk about is about sinus lift. So again, this is another article, again, by my great friend, Dr. Carlos. Again, I'm just picking up these articles. There are a lot of articles out there. This is just an example. Okay, so which supports our sinus lift grafting here. Again, this is another one of those cases that we see a lot in our practices. What's unique about this case is that I didn't use any bone graft particulates in this case. Patient, he was a diabetic and patient and very worried about doing a sinus lift, very hesitant. So we decided not to use grafting. Sorry, I think that's a video, but for some reason it's not playing. Maybe it's looking at this sections of the CT scan. You can see we don't have any bone basically, and it is a complicated case as well. So we draw blood, we spin him, and this is a little video. So sometimes I like to, when I make a window for the sinus lift, I like to actually save that window. Okay, I know a lot of people don't do that. I'm not sure. Maybe I just sometimes feel like maybe I enjoy removing that. It's a challenge for me, or I like to save it because I know I can put that back on top when I'm closing, and kind of like that better. So anyway, it's a short video. There's a lot of other way of doing this. There's a lot of implant companies have systems where you can basically just make a hole and elevate the sinus membrane. So we elevated the sinus membrane, the Schneiderian membrane, and we'll make sure that the patient breathes in and out, make sure that we haven't made any perforation. We place our implants. His membrane was really thick, so I wasn't really worried about perforating it. So once we place our implants, now we're using the PRP gel or the PRF. Excuse the video becomes blurry. I just use an iPhone, and this was late at night. I was doing this. I usually have 2 assistants helping me. This was just 1 assistant, and we were trying to do this. But basically showing you that we're just placing the PRP gels and PRP membranes inside the sinus for our procedure. And these are some CT scan techniques. So we waited about 6 months. Again, showing you some numbers around the implant, which is about 751. This is great results. Not using any bone in the area. So just use patient's own blood and no blood particulate. Of course, this is before and after. This next case is another sinus lift procedure. This is through Crystal. And again, we have a lot of these cases in our practices when people come and they have 3-unit bridges, and so what would be the option that we give to our patients if we have a simple, predictable way of doing this by not doing another bridge? So again, we measure this area. We only have about 3.4 millimeters, so we can easily do this in a Crystal manner and place our implant. So in this case, I used hydraulic pressure using a diode implants sinus lift kit, where so we use the saline water to lift the sinus membrane. And then I place some bone graft particles in there, plus some PRP gel. And basically 6 months later, patient comes back, we take another CT scan, and it looks great. Looking at the bone density there, it's about 506, which is great for a sinus area. And again, there is a little bit less, about 300. Again, this is so before and after. That's a great result. So again, this type of procedures only takes maybe about an hour, start to finish. Patient has a temporary bridge. They can stay on there. You can permanently glue it, and so this is another case which was it took actually a long time. Maybe it took a couple of years for me to finish it. This patient was referred to me by another colleague. This patient had a sinus defect, basically. After an extraction, it never healed, so you can see the sinus infection. So when we spoke to the patient and decided to see what we're going to do here was to basically just clean the area and obviously use blood derivatives to just graft the area to try to close that defect. So we did that. We waited about 3-4 months, and you can see there that communication is completely healed. So 6 months later, we brought the patient back, and I did a sinus lift and basically try to augment the ridge as best as I could. You know, I was not 100% sure if this case was going to go, so I told the patient knew. So that's very important to communicate that to your patient, so they don't have that expectation that this is going to work or not. But it did in this case, and it gave us a great result. So when we measure this, you can see the sinus is completely cleared up, and we got about 10 millimeter of bone, which is a fantastic amount of bone for placement of our implants or bridge or whatever we're going to do here. So again, that's the density about 674, which is great for maxilla. So we place our implants, and this CT scan actually is at 3 years post-op, showing you the bone level, still great in that area. So patient's still there. This is actually a very old surgery we did years ago. Again, so this is how we started with an infection, with a defect. We repaired the defect. We grafted it, did the sinus lift, grafting, and placed our implants. So again, sometimes we cannot do everything at once, and we have to do things in stages. So all that needs to be communicated to the patient, so they're understanding and they don't expect otherwise. Next case, we're going to talk about soft tissue technique. Soft tissue, again, this is another article by my dear colleague, Dr. Myron. This is the use of platelet-rich fibrin and soft tissue wound healing as a systemic review. Again, there's a lot of examples of this out there. I'm just giving this as an example for. So this soft tissue techniques, you know, there's a lot of names for it: pinhole, Vista, laser-assisted thumb lift. That's my technique. But basically, so we're using this PRP gels or the PRF membranes to basically bring back the tissue. And I tell the patient it's like a facelift for your gums. We're basically just going to lift it up and bring it to where it should be. So again, we only worked on the maxilla here. in this case. So you can see the amount of recession that she's had in some areas, maybe about 7 millimeters. Again, we draw blood. I remember for this case, we'll talk about this later, but we had to draw. I had to draw twice, and so this is what the tissue will look like where I've already lifted, and this is right after when I do this composite to secure my sutures and secure my graftings. But this is basically after showing you some great results. So before and after, again, we did not work on the lower, just work on the top. So it's amazing, and believe it or not, might seem complicated, but it's fairly a simple procedure. It's not very invasive, minimal pain involved. There's some swelling. When I used to use collagen membrane, a lot of patients would have a lot of problems, a lot of pain, a lot of post-op issues. If you ever had a perforation in the gum, those areas would not heal for months. And you never have these issues when you're using the blood autologous derivatives. The healing is a snap. It's really quick. Again, you're looking at this area of this premolar, and I know we didn't get a full coverage, but you can imagine we at least got about 5 millimeter coverage there, which is still amazing. Because again, you can always do this again. You can always repeat that procedure and that side. It doesn't cost much. You draw a couple of tubes and lift the area, but I would wait a good year before I do that again. So, so again, this is the same patient, and you can see it's 2 years later. A patient came. I just snapped a quick picture from her. So that's great results. Again, minimal investment. And great results for the patient. So we can also use these blood derivatives in facial statics. Again, these are 2 different papers here. One from Dr. Cleopatra, and this other one from Dr. Masako here. So again, these articles are talking about the use of basically platelet-rich fibrin in soft tissue healing. So basically, we are using, we're denaturing the albumin in the ovens. So there are multiple ovens that you can buy to do this, and this, I use the Cephalent oven, but so we can basically use this gel. You can do this intraorally, or you can do extraorally. You can inject it even intraorally. So if you don't want to get into the extraoral, I know some doctors have an issue with that. And so basically you can prepare these gels, patient's own blood, and you can basically fill the areas that are deficient in the patient's in the facial statics area. So I wanted to talk about, this is the cases that you can do. Again, we'll talk about minimally invasive, right? So we want simplification. I want to do things easily. So when we get a patient, and this procedure, if you look at it, it's been done before. It's called vilcodontics, and this procedure, I'm doing it, and I call it Invisodontics, basically. So they use braces, I use Invisalign. Again, it's patient, young patient, and you can see she has a crossbite, she has an underbite, class 3, and so what would be our options here? So you can see how much of underbite this patient has. So obviously, without a doubt, 99% of general dentists would say, "Hey, you need to go see or a surgeon. You need to go see an orthodontics, because you need the fourth and major surgery, because there's no other way of fixing this." So, and you can see how deficient her left side is. So it's not just the teeth, but her facial statics, the facial symmetry is off. And so when we look at this, we want to see what are our options. So I decided to just do this in a not non-traditional way, a lot less invasive. Okay, so minimally invasive. So when we look at this image after I lifted, so I decided to do this in multiple stages. So I'm going to actually I was going to actually do the invasive odontics initially, but when I reflected the flap, what I noticed was that this patient, without ever having any braces, she had dehiscences from in this area. So all her roots were showing there. So it's not a wise idea to do any type of orthodontics. Again, these are the things that we do not see even with a CT scan. It's it's so hard to tell that if somebody has major dehiscences or defects underneath the tissue, and we would never see it if we didn't flap it. So again, when you see a lot of patients, when they get braces done, after braces, they end up having recessions, either on the buccal or on the lingual or whatever. But you see, so there's obviously things that we don't see, and we obviously act on. So again, this is just showing you the area at the moment, and you can see that the area of the dehiscences that the patient had, and that canine, the lateral. And so we prepare our sticky bone here using the obviously we use the white tube, and sometimes we use the some of the liquids from the red to accelerate our for this bone to become sticky and a glue-like. So there goes the grafting material we placed. So my goal was to basically move this corner of her mouth out to compensate the deficiency of her overbite and underbite. So I'm using here is a pericardial membrane against a very thin membrane, easily formed, and it does not take a lot of space, which is very important. Okay, so again, making things simple. We don't want thick membranes, we want thin membranes that form easily. And so we place our PRF on top of that, suture it up, wait about 6 months. Bring the patient in. You can see the bone now completely healed over, and you can see how thick this is. This is amazing results here. Again, just place the bone. You do you do the flap. You put some bones, membrane, close it up. Patient goes home. You wait 6 months. You bring the patient back, and so here we're using a piezoelectric ultrasonic machine here, where we are actually going to cut through and through all the way to the lingual. So at this point, I'm going to section in between all of her teeth, pretty much from the central all the way to her first molar on this side. And you can see how hard that bone that we place is. Still kind of difficult for me to cut through. So I'll mark them first, and basically where I wanted to cut it, and I'll come back and go a little bit deeper because I also didn't want to just overheat the bone there. So I'm just marking, and then I'll come back and go a little deeper. So you can go in between papillas too. It's not a major issue, but there I'm just cutting through the cortical bone, and you can see that this is basically you can see the grafting material there's still there. So if something comes off, then no big deal, because I'm going to regraft anyways on top of this, because in this case we have to do a lot of movements. As you can see, I'm going to cut all the way to the first molar, including the first molar, because we're going to be moving all of that. So again, this patient was treatment plan, and we already fabricated her Invisalign. So right after the surgery, the patient walks out with her Invisalign, and so all the way to the first molar. And you can see some, and so they'll come back and I'll go a little deeper. And if there's anything there, again, I'll remove little particulates there that comes off, not a big deal. Again, this is our own grafting, and I'm going a little deeper here. So next, from here again, so this is the cut slices through the teeth. And you can see visibly here, again, the particulates, the oral bone grafting area. Again, so I regraft the area because I'm going to be doing a lot of movements. I'm going to be doing a lot of movements. I want to make sure we have a lot of bone. So, and in this case, I did not place, the second time around, so I did not place any other type of membrane because I'm not going back to open this up. So, suture it up, put the patient's hair Invisalign, and this is a rapid phase Invisalign again. So we don't go traditional speed. We tell the patient to change your aligners every 2-3 days because we want that movement before the bone starts healing. So this is the patient coming back after 6 months. Again, I can see she's still on Invisalign. She has her trays on the top, but you can see the difference that we've already made, that she's now almost edge to edge. Crossbite is almost finished, done. And you can see the other thing that is very interesting is look at the gums. I mean, I know a lot of you would be worried about, hey, is that gum going to come back, or is she going to have some black triangles or something like that? But look, it's amazing. The gum healed really nicely. And this is just showing you her before and her after. So look at how easily, I mean, I understand cutting with the piezo may be a little invasive. That's the only part of it. But compare that to doing a orthodontic surgery for this patient. So we're not obviously done. I'm going to do a second round of Invisalign with her. This is going to be at a normal pace, and but that's great result. Again, that's not what I call the minimally invasive dentist, because we are not sending our patient to get basically have her jaw cut up and then a whole bunch of brackets put on and months of closed shut mouth basically. I've seen a lot of people go through it, and it's not easy. Anyways, this next example is my procedure, which I call it laser assisted recession procedure, or LARP. So this patient, as you can see here, had major abfraction, right? So normally the question would be, what is your treatment plan? right? I mean, we can do root canals and crowns. We can do, you know, it's hard to tell, right? I mean, when you look at this patient, you will need to do tons of root canals, tons of crowns. And what would your crowns look like? You know, we would have a very, very unstatic results. So I wouldn't want to do that to my patient. I wouldn't want to have that patient walking around telling them that I was the dentist, basically. So again, this is all due to malocclusion, basically all these abstractions and these years of neglect, not only on the part of the patient, is also on the part of the dentist who this patient has been going to, because they never address the main issue, which is the malocclusion. Okay, it's not brushing hard, or it's not, you know, even the grinding, I would say, because if let's say you make them a night guard, but still the patient has a you know, they don't wear their night guard during the day, so that malocclusion causes all this trauma for this patient. So in this case, basically, again, here we are putting our patient on Invisalign immediately. Okay, we don't want to do a procedure where we know that occlusion is going to cause this recession again, or that abstraction again. So we're replacing our buttons. So I call it laser assisted because I use the water lace. It's the BioLace made by the BioLace company. I use it to basically prepare all the areas that we're going to on the root surfaces, and basically it cleans off the area, but it also preps it in a way that we can get a better and renewed epithelial attachment in those areas. And you can see how nicely those are prepped. And I also use the laser for my basically cuts through the vestibule. And it's amazing that the results that we see from this is because of using the laser and the reduction in bleeding. And you can see this is right after I've already gone through. I'm going to make those holes bigger, but you can see there's no bleeding there whatsoever. So when we do these cases, again, there are not a lot of pain involved, but there's a lot of swelling. So using a laser reduces that. So again, here I'm just using a regular mold here to lift the gum area. Again, you know, we use a lot of this PRP gels or PRFs. So just placing those guys inside underneath the periosteum. Nowadays, I make the holes a little bit bigger. Okay, so this is an old video, but so this is right after the surgery. Basically, we've lifted this hole. You know, again, I tell the patient that this is like a facelift. You know, I mean, to lift your gums to their original position. One thing I wanted to tell you, one of my most favorite restorative materials is the IRM. In a lot of cases, when I don't know what to do with something, I just put some IRM in there. This tooth almost had, when I was doing the laser preparation, here, this guy almost had, you know, we were to the nerve. So so I just put some IRM in there, and believe it or not, he went through this with this IRM for maybe over a year without anything, because didn't want to get anything done at that point. But anyways, that's right after. Showing you a picture. I didn't want to pull up the gum too much to take pictures, but you can see that the sutures are still there 2 weeks after. This is amazing. Look how fat that is. The gum around the Invisalign right there is. So again, there's still some swelling there, but they're all still there. So this is a 2-month post-op picture. In this case, we've already done the lower as well. and this is a 1 year post-op. So again, this is, to me, this is minimally invasive. This is, you know, I'm able to save my patients the correct their bite, and the cost of doing this is a lot less than doing 28 root canals and 28 crowns, and you know, I can always crown these teeth, and they're going to look great. But you know, if I would have done it in the again, we're looking at before and after. This is just humongous difference between these two. Patients super happy. Again, this is the kind of cases that you'll get so many referrals from this patient is going to be yours forever, and they're going to advertise for you because you did the right treatment for them. Again, imagine putting crowns on those guys, and it would be really an static nightmare. So this concludes the portion that I want to talk about why we use it. I also wanted to talk about this system. It's called MudFix. I don't use, again, a lot of pins or screws or anything like that, but if this system was developed by my good friend and colleague and my teacher, basically, Dr. Homazadeh. This is a great system. This is a genius system, and I had the pleasure of going to one of his lectures recently, and it's just amazing. This makes life easy. I'm gonna have to throw all my pins and screw kits away and start using this, but has great yeah, I just wanted to share that. Shout out to Dr. Zadeh. A genius invention here. I'm so excited. I want to share that with you. So you can easily place these, and they're different heights, and you can even do vertical ridge augmentation with this when you don't have anything, and it's great. So again, what we did was it not involve any pins or screws, but I just wanted to share with you that nothing's, we can't use that for every situation. Some situations we're gonna have to some pins and screws. So next thing we want to talk here about is about the revenue. Why we would do it? Obviously, there has to be some financially something involved. So in my hands, in my practice, it saves me a lot of time. Okay, it makes things easy. It also helps me save on a lot of bone graft material. So it helps me save on membranes. So in a lot of cases, we can use this. So what happens when we hydrate, when we use this blood derivative material and we hydrate our bone, what we see there is that we see an expansion of the bone particles, and that also basically when you also mix your fibrin clot or your PRP gel in there, so that also that's a filler that increases that because remember this is just on a scaffold, right? So the less bone we use, and obviously you save the money there. So using this will help us. And again, this is a membrane. I put that picture of that membrane there, so I want to make sure I want to talk about it because it's not a barrier. It's a membrane. So basically, it's a short term, maybe 2 weeks, 3 weeks max, if it would stay there. So but it could be used for most situations, so it would cut costs. And the most important thing for me here is, and I do this for almost every one of my extraction. I use PRP or PRF or sticky bone. So, and how it saves me from, and I would like to use it is a time, because so we have this patient who comes in who's had a tooth in their palate for God knows 30 years, 40 years, and if I'm going to remove it, I'm going to definitely make sure I'm using some bone grafting and some PRP membrane. And you see how easily that's handled. And I could pick it up with cotton plier, plug it in, take my membrane, basically with my cotton plier, plug it in, and basically, look, I'm just using a plugger there to push it in again. So showing you the picture right after. So easily handled. And easily placed here. Okay, so this is patients with the tooth there. This is right after. What's important about this image right here, this actually I had the patient come back after 2 days, and I took this picture, and you can see already some vascularization around it. So definitely healing, faster healing. It's we can see that, and it's amazing. Again, this patient lived with this tooth in his mouth for 30-40 years. I wasn't just going to remove it and just leave the socket alone. So obviously charge the patient. Our fees are differ from place to place, but you can always charge for that, so you're more productive. I am not sure how much time we have. I'm just going to take a quick look here because I'm not looking at this the screen. Okay, so I'm going to keep going, I guess, till I'm stopped here. But so next thing we wanted to talk about is I'm going to talk about we're going to talk about some phlebotomy, basically. So what it takes and it's for you to incorporate it in your practice. So here's a video that we made, basically showing you the whole procedure and what you have to do A to Z, and going through the procedures that we use it for. So again, we survey area. Our favorite place or the most ideal place to take is your antecubital region. So we always have to inspect both arms, make sure, because you never know when you are going to miss. So it's always important to basically survey both hands, know what's best area to draw your blood. There are complications. There's some standards in blood drawing. I know a lot of dentists who basically just buy a centrifuge, and the rep holds off his hands and says, "Here, just go ahead and try." And they don't ever take a training course on drawing. I know we have courses throughout the year. I know Dr. Kayvon Javid has courses throughout the year. So I believe it's very important for you to be educated, because believe it or not, there is bigger organization on blood drawing and standards that Department of Public Health looks over it for the licensing, and so there's standards and there's legal issues involved in this too. So you need to know what you're doing. Again, I'm not saying it's complicated, but I'm saying is you should be informed and know what the complications are and what you should do for the complications. So again, again, one example would be this is standard of care. So you have to. This is a 2-point check here. We put a gauze, we put pressure, we let it go, we check for bleeding, and then we apply. I like to put this medical bandage over just a small band-aid, because that puts pressure in there, so we make sure there's no bleeding involved for the patient. So again, so we take the blood and we use a centrifuge. Again, this centrifuge is different. If you ever get a chance to watch Dr. Kayvon Javid, he just had a webinar that I had the pleasure to watch it the other day. It's very informative. I learned a lot. Again, I always do watch watch webinars and read books and articles, and I always try to keep up. But his webinar is very, very informative, wealth of information about all these different centrifuges and basically, I would definitely recommend you watching it. So again, we draw the liquid from the appropriate sides of our tube. We prepare our bone graft material. We prepare our membrane, and here we're using a device to flatten it, and then we can use it in different situations, such as just grafting a socket or so. Going to just pass that and look at some anatomy quickly. I think we're running over a little bit maybe. So looking at anatomy of the venous structures here, and the blood pressure of the venous system. So so the venous flow, so the blood flows from the arteries, goes to the arterioles and to the capillaries and to the venules and to the and then to the veins, and starting from bottom up. So that's important to know. So the blood's flowing up, for the venous system. So again, at the feet, they're about 90, and as we come up, around the neck, it's about 0. So we want to be that's the reason why we draw from we like to draw from the endocubital region, is because that's a good low rate of blood flow, so we don't get postoperative bleeding there. Again, this showing you the area that we use is a branch of the subclavian, basically the brachial and the cephalic area. This slide just shows you that you get collapse in the arms. So it's very important where you situate your patient. So if you raise their hand too much, then you're collapsing those veins. This showing you that the basically anatomy, the differences and similarities between the veins and the arteries, pretty much the same exact thing. The only differences between the artery and the vein are basically arteries have pulse, they have oxygen in the blood, and veins have valves and that the oxygen in the blood. So this is important to realize, because when you're drawing blood and it's red, is super red, then you know that it's obviously not if it's very bright red, then you know you draw from the artery, and you need to basically put a lot of pressure in that area and hold it for a longer time to make sure that there is no bleeding involved. So again, this is showing you the structure of the vein. I'm going to run out of time, so I'm going to speed it up. But showing you there's different configurations here for the vein. Here we have the edge configuration, again showing you the cephalic vein, the accessory cephalic vein, the basilic vein, and again the end configuration. Yes, we are running out of time.
You have plenty of time. Take your time.
Okay, perfect. All right, so I'm trying to speed up, so I'll go back. So there's two configurations. What is the edge? One is the edge configuration, and one is the end configuration. Again, so this differs between the patient. That's why we have to look. It's never the same for every patient. And so again, here showing you just two different configuration. Again, this slide, this area, but it's very important to also know that why is it's important to draw from the right location and not, just not to poke people and try to fan out that needle because you could cause nerve injury. So one of the major complications with blood drawing, again, if you look it up, you'll find cases, legal cases, where people in my course, I go over this, but in a lot longer time where I'll talk about the complications. But you just want to know that there are areas that we wanted to go. There's preferred areas that we wanted to draw blood from, and areas that we wanted to avoid. So, and all this also needs to be documented. So when you're gonna draw blood, you need to document it to see where did you draw blood from, which way did you draw blood. Because if something happens and that patient goes to a lawyer and they send the patient to an expert, they're gonna know where you draw blood from. So you better know it too. So it better be documented. So anyways, this is the preferred sites for venipuncture are obviously your antecubital fossa and the back of the hand. I don't like back of the hand. I only use it once in a while if I have to. Okay, it's not my favorite place, but I always try to find it in the antecubital fossa, and it's always there. Even, you know, it gets more complicated when you have patients who are obese or maybe older patients who have veins that are rolling, basically. So other sites are not really permitted. Again, in my course, I go extensive in what we can do as dentists and what we can do, and basically all the standards. So this next thing that I want to talk about, and we're going to finish here, is basically we talk about blood components, a little about PRF, and we'll be done. So blood components, basically, you know, average people have 5 liters of blood, and you know, if you look up the literature, you find that, you know, death, you know, could happen if you lose 30 to 40% of your total blood. So that's always a question: how much blood can you draw from the patient? And you know, so actogenic anemia is a condition of lowered hematocrit and hemoglobin count resulting from a large or frequent removal of blood samples. So again, for what we're doing, you know, 12 vials or even 16 vials, I wouldn't worry about it. I would worry about it, again, go back here. So I would worry about this if you have a female patient who's anemic. So you want to prepare that patient and not take too much blood, not more than 12. Again, and nothing's going to happen. They're just going to have some reaction. You know, they're not going to feel good for a few days after. So that's something to consider. So what's in the blood that we spin here? So obviously we have the plasma, and then we have the red blood cell portion. So you can put a tube of blood in any centrifuge, and you can spin it, and you'll get this. But the question is, what is in that separation? What is in your plasma section, and what is in your you know, what's in your red blood? Because if your centrifuge is not at the right settings, you're going to be pushing all those white cells into the red blood cells, or going to be basically destroying them by too much force. So when you look at it, you see that, you know, 54% of that blood that we draw was the plasma. And again, this varies patient to patient, but this is the average. That, you know, so about 54%. So, you know, you have the plasma, which includes the gases, waste, the nutrients, the proteins, ions, and water, and the red blood cells are about 45%, and the white blood cells and the platelets only constitute less than 1%. So this is why it's important to have the right centrifuge. Again, you can buy a $100 centrifuge from eBay and start spinning your blood, but you know, if you're going to do something, so again, the investment is not $100,000 laser machine. You're talking about $1,000, $2,000, you know, $1,800, or, you know, for the whole setup. So I would definitely recommend, again, you know, buying a reputable centrifuge that can separate your layers properly for you. So obviously, what we get here are the growth factors. Growth factors are very important, you know, because they regulate a lot of cellular activity. So they're the guys who are going to go tell those mesenchymal stem cells to become bone or cartilage or whatever else that they're going to become. So obviously, when we're drawing this, we want to make sure that we use the right centrifuge in the right setting to get maximum amount of our growth factors. So they're basically naturally occurring. They basically stimulate cellular growth, proliferation, healing, cellular differentiation, and these are some examples of growth factors. Again, so very important. You know, for example, we're looking at all this. Again, we do not get BMP2. That's just an example of growth factors. But what we do get, say, VEGF, vascular endothelial growth factors, or fibroblast growth factors, or platelet derivative growth factors. So are very important in our tissue healing, connective tissue growth factors. So very important for healing. So this is very important to have the right setup and have the right so we can use the maximum amount of growth factors in our for our patients and for our results. So again, there is a great market. Their biologics, sells some of this. So this is the recombinant human platelet-derived growth factors, and they're very pricey. You can see that. So I mean, and these are micrograms. Okay, it's like 3,000, 4,000 under. It's just amazing. So you can do this. Will cost you probably a couple $dollars for each patient. So really minimal investment after you buy a proper good centrifuge, and go through the training and learn how to draw blood. And so you are you are what you eat. This is a good example. I draw this one time, and I draw this patient's blood, spin it, and it was completely green. So I'm asking her, did you you eat a lot of vegetable or greens and stuff like that? So she actually pulled out. She was on a kind of juice diet, and she pulled out this juice, and look at the color. So we are what we eat. So it's important what we eat. And the point here I wanted to make is that a lot of our failures sometimes it's not because of what we do. It's because we do the same thing all the time for all the patients. So the failures a lot of times is the biology of the patient, is what they eat, is their behavior, of how they basically basically their biology. If they say, for example, have high cholesterol, that's well documented where that can affect your grafting. So again, we can see a lot when we draw blood from the patient. So lipemia is obviously presence of high concentration of lipid or fats in blood. So when we collect this lipemic blood, we can see that they're milky and cloudy. So this is an example. So to the right, you can see normal blood, and then to the left, you see all this lipemic blood. So I mean, you might think that whatever you do for that patient might not work. So again, this is well documented. Vitamin D and cholesterol are very important. So lower cholesterol and higher vitamin D definitely help with your bone grafting. So again, we do also see a lot of stuff when we draw blood about our patient. We learn a lot about our patients. Again, so I'm not going to waste a lot of time on this guided bone regeneration and guided tissue regeneration. Just so I want to give a little history on PRF, CGF, sticky bone. Again, so there's all this nomenclature out there. It all started from PRP, and people come up with different centrifuges and start naming it differently. So it's caused a lot of confusion. I was confused initially when I didn't know what was what many years ago. But if you look deep enough, you'll find in medicine it was introduced. Sometimes in the 70s, it was used with different patients with thrombocytopenia, and to encourage this healing and stimulate healing soft tissue and joints. But that's what's used in the medicine now. But in dentistry, basically, started in the early 90s. These are two articles. Again, this is one from Dr. Marks, and this another one from Manito. Again, this is early 90s. Obviously, Dr. Arun Garg, one of the pioneers of the PRP. Again, very informative webinar there, and that book is an amazing book. I would definitely recommend it. So if you guys want to get into it, then I would definitely recommend reading that book. And then in 2001, PRF, with Dr. Shokru, and he's not a doctor, but somehow I have it as doctor. But we always have that feeling that he's a doctor. Anyways, so the platelet-rich fibrin, they wrote about it in 2001, and with the increased demand of tissue engineering, so we went from PRP, with PRF, CGF, and so anyways, it's an evolution. Again, this is a marketing also tactic where it's the same thing. People just naming it a little differently and making it a little complicated for people. But I use CGF. I started using this Slifferdent, the unit always, and this is just settings for it. So again, same thing, make things complicated. But I would like to thank obviously all the pioneers who came up with this technique and this idea, and how amazing it is. But also I would like to thank all the people who are on the front line and the cutting edge technology. So these two articles, one's actually they came from my dear friend Carlos Maro and Dr. Iziagano, and Dr. Kurtzman, and myself, and all the others. Again, this is about ALP CGF. This basically the denatured. It's a heated PRP basically. So, and this other article is by myself is on ALP PRF again. So again, basically it's a heated and manipulated PRP. So we get a different membrane now. So now here, we're not just looking at the membrane. So this is possibly could be a barrier, because this type of new membrane, and you can see the difference between the old membranes that we use and this new membranes that we have now, that these could actually now be some sort of barrier, because they could last a long time. So these could actually last for months. So now that we come into a whole different, this is a whole different ballgame now. And so I appreciate both sides, the pioneers and the people at the cutting edge, and bringing us new stuff and exciting stuff. So again, always working on making a better block of bone grafting, the way we can actually carve and make things easier for us. And with that said, I wanted to basically we're going to end our presentation here, because I know I've been way over time, and so.
Okay, well, that's excellent.
Thank you.
So I think there's some questions that came up, but they came up early, and I think you answered it later. It was about the cost of things, and I think you answered later that the cost of test tubes is $1 or less,
right?
And the centrifuge is about $1,000 or so, and
very inexpensive. Very inexpensive.
Yeah. So did everyone hear that? The centrifuge is about $1,000 or so. Test tubes are less than $1. That's U.S. pricing. I'm sure it would be commensurate pricing in your own country, but something very, very inexpensive is to use there. Okay. In terms of speeds, it would depend on your centrifuge. Clearly, the larger the centrifuge, the slower you would go. The smaller the centrifuge, the faster you have to go in order to get the same G-forces. So if there's a question about what speeds to use, it would depend on your centrifuge brand. None of us would say generic speeds, because it depends on how big the rotor arm is. So if you buy a quality centrifuge from a quality company, you would go by their settings for it. You couldn't go to YouTube and say, well, I like the settings the guy said on YouTube, and I'll apply them to my centrifuge. It doesn't work, because it's based on the rotor arm for your specific device is there. Absolutely. The invisible orthodontics case that you did.
Yes.
So you made the cuts, and so how much does it shrink the time? There's a question: how much does it shrink the time compared to had you done Invisalign alone? Or is
so
it just the fact you could able to do a case that you couldn't do otherwise?
Yeah, absolutely. So I mean, I do this just to. I mean, you can do it, but I wouldn't just do this just to do an Invisalign case. You know, I mean, of course, if the patient already had braces and we know they've already gone through orthodontics and we know, so they might have some dehiscences and some defects underneath, then I would definitely recommend it. So we can easily. So I do that all the time as well. So when somebody comes who says I've already had braces for 3 years, 4 years, I know they're gonna have defects underneath. So I do a flap, I graft the area, and I feel confident at that point to not even go back there and just move. You know, you could cut it if you want to before your first graft and do it. So yes, I mean, you know, you can use it. You know, I wouldn't use it for a regular Invisalign, but if you have a severe case where you can move a lot, you know, then I would definitely use it, especially if the patient have had already some orthodontic treatment.
There's another case question there, that do you make the cut only through the cortical plate on the buccal, through the cortical and cancellus, or through cortical cancellus and the palatal cortical plate?
Yeah, I go through and through. So you know, I go through and through. So because that just makes it a lot easier. You know, you can try to just push it out, but you know, you go through and through. Again, when I go through it on the other side, I try to be conservative. I'm not trying to poke out of the palate. So you know, being conservative again. So I also not overheating the bone. So you know, I spend a lot of time doing that. So little by little, I do little by little as I do it.
And then there's a question there is why do you add the bone graft onto it afterwards rather than leaving the cuts as they are?
Just so, I mean, you know, you as you saw, we had enough bone there, but you know, I already made the bone graft there and I had it there, and it is no harm in doing that because I know that's just going to take anyway. So first time took, so I know the second time, especially when we're doing all that cutting and we know we're getting bleeding down from inside the bone there. So you know, preparing the site. So, but just to make sure, because in this case I was gonna, so I'm not only aligning her teeth, I'm actually moving her jaw forward to the left completely. So if you look at the clincher for that case, you will see that that the movement is almost impossible. So we would actually drive her teeth out of her mouth to do that. So, and that's another reason. So I'm just bulking up that area to compensate for our movements that we're gonna have.
And then you might have mentioned it earlier on, but there's a question about what type of graft material did you use in her case and the other cases?
Yeah, so I normally use a autologous bone material. I'm sorry, I use an allograft. I use allograft normally in most cases, but I do have both xenograft too. So, you know, I use xenograft in a lot of cases when the patients, I know they're not going to come back. And there's no plan for something in the future. So if they just want to do grafting and they want to get a denture, or you know, they just say pull my tooth, you know, I don't really care. So I just, that in those cases, I use xenograft. And normally when I do extraction, I make sure that the you know, this is the new thing that me and Dr. Carlos are working on. Our basically is this new technique that we're doing. It's called an open technique, open concept techniques that we're basically avoiding flapping, avoiding suturing, avoiding you know, and we're basically we wrote a couple of papers already that's going to be published. But yeah, I use those in those cases. I use the xenograft, where I'm not going to go back in there. If I, you know, or sometimes in the sinus, I do a 50-50 mix. But for most other cases, I use the allograft, just human freeze dry human bone, and as far as the percentage or the, you know, I like to use the smaller size of the particle, but you know, 50-50 or that doesn't really stand really important. I haven't seen any difference. But the smaller particles are better, definitely. But making a sticky bone, always, I think that the allograft works better than the xenograft. It holds better together. So that's one experience I've had.
Excellent. I think that's the questions we've got, Doc.
Thank you
very much for coming on. Okay, thank you for all the participants for participating. Please check the schedule. We've got programs going on through the end of the month, all completely at no charge, no fee, and bringing the best speakers from all over the world for you. Thank you.
Thank you, Dr. Adam. It was an honor. Thank you.
Thank you all for joining in and for your contributions to the project. Have a nice day, guys.
You too.